the 22nd International Symposium and 15th International Conference on Lameness in Ruminants. And as dopo. No. Technical aspect, logistical aspect, because here is lunchtime and we have, not for us, we have forced Professor Shearer and Professor Mortellaro to come to our webinar, and therefore they are organizing to bring us something to eat. But I told them that we can postpone. So, as I was mentioning to you, we are here at the venue of the Congress in Venice, in this very nice town. Perhaps you can see behind me the port, the sea from Venice. And there are more than 400 participants. The organizing committee kindly invited me to introduce the World Association for Pediatrics and to present the World Association for Pediatrics during the opening ceremony. But now I would like to introduce first the speaker, that is Professor Shearer, that graduated at the Iowa State University. No, sorry, he graduated in Ohio. It's difficult for me to differentiate Ohio and Iowa. Anyway, he graduated in Ohio. Then moved to veterinary practice and spent 5 years as a pediatrician, came back to Ohio State University, and then moved to Florida University for where he remains there for 27 years as extension veterinarian. And then he ended up at the Iowa State University, where now he is professor and extension veterinarians. He devoted his life to bovine lameness and also welfare issue in cattle types, and especially competencies in euthanasia, and therefore as a euthanasia as a welfare aspect. But before starting, as I already mentioned it, unfortunately, Professor Mulling from Leipzig had a problem with the car, therefore is still on the way for arriving to the Congress, but Professor Shearer is kindly able to take over a little bit the time of Professor Mulling. But as I mentioned to you, I have a surprise, and the surprise is to have here, and I want to show you, because he is an icon of veterinary medicine, and he is Professor Mortellaro. He is an icon, but he's still active. Yesterday he trained trainees at the workshop, and Professor Mortellaro is well known all over the world because in 1972 he practically described for the first time one of the most important diseases in bovine, that is the digital dermatitis. And therefore I asked the Professor Mortellaro to take some time to give us 2 minutes, and just to tell Professor Mortellaro, please tell us something. Also from there, I start with the microphone here. If we are able. Yeah, Professor Mortellaro, I think all of you can, I now can see Professor Mortellaro. So yes. One of the most important person in veterinary medicine. No. In fact, all a pediatrician knows that there is the digital dermatitis is also named Mortellaro's disease. Therefore, we have the Mortellaro disease, but here we have Mortellaro himself.
All right, we have time, Mortellaro. Okay. And can I speak? No?
Yes, you can speak.
So, I'm Dr. Mortellaro or Professor Mortellaro, and probably I'm the oldest on this conference room, no? Together with you.
Yeah.
Yeah. And I'm 74. I'm retired. I'm still passionate of language and cattle. And although I did practice since many years because I have some problem with my hand, probably in my brain, and not just in my hand, in my feet. And I gave this morning a story on the unknown story for most of the participants. And not a scientific presentation, but just the story when this disease were discovered, when was discovered, because there is some debate between discovery and description. So actually, for you, the disease was discovered in 1972, although we use a wrong name, and the first real description was made later. So, and I must thank Professor Caldo Gentile for inviting me to see this work. No questions are admitted, so you can't address questions to me. And probably you can send me an email, Professor Caldo Gentile. Is one of the recent friend of mine. And I don't know, he still call me professor. They say, why not you Carlo Maria Mortellaro? No, he said, Professor Mortellaro. I'm not happy for that because he's a great man, more important than me, sure. No, because I did fortune or misfortune to report that this disease that is still a tragedy and it's still very, probably one of the strangest disease in this moment. Probably the deficit control is far from to be reached. So we try during 3 or 4 days to add some new information to prevent, I don't know, but to cure this disease. Probably there was a recent paper, the last paper this morning, given by a colleague from USA, Dr. Doffer, and he showed some new modalities using the drone or artificial. So probably we have to move to other tools to really prevent the disease or to treat the disease, and probably as in many other diseases in human, like cancer, probably the answer is not clinical, it's a genome, so it's genetic. Okay, so it's not enough to be able to make a diagnosis, to make a therapy, etc., etc. Now, as many disorders in human, Alzheimer's disease, cancer, many cancer diseases, probably the answer, not now, not nowadays, but in the future will be investigate the genome. Thank you so much for listening.
Thank you, Professor Mortellaro. Thank you. I know that you have to leave. You have to leave for
no
taking care of the Congress.
Yeah. Okay.
Thank you. Thank you, Professor Mortellaro. So you have seen now, Professor Mortellaro, everybody can say that has met Professor Mortellaro.
Suggest them people to use DD and no Mortellaro disease, okay?
Professor Mortellaro said to use the term digital dermatitis and not Mortellaro disease.
Deleting Mortellaro, okay?
Yeah,
it's not my merit, okay?
Yeah, but okay, but you did in 1972 your thesis in digital dermatitis. Thank you very much, Professor Mortellaro. Thank you for coming here. So now we start our let's say scientific part with Professor Shearer. Therefore, I share the screen and we can start. Okay. Peter, confirm us that you can see we can see the presentation.
We see the PowerPoint, but not the single slide. Now we have the single slide. Yep. Perfect. That's fine.
Okay, Professor Shearer, thank you. To you.
Excellent. Thank you very much. This is a real honor. Thank you, Dr. Gentile, for the opportunity to share some thoughts with you on practical therapy of foot lesions. It's something I've been looking at for some time now, and while I don't have time to go into great detail on a lot of these specifics, but I wanted to share with you at least some of the work that's going on and some of where I think we are with respect to therapy of foot lesions. And so this is a great opportunity to do that, and I appreciate it very much. First of all, I think to get us started in this whole discussion of lameness, we recognize that it's basically the manifestation of pain in one or more feet and limbs. It is a very significant cause of poor animal welfare, and one of the most important diseases we deal with in the dairy industry, but it's likewise a huge issue with respect to the cattle industry and our feedlot industries and our cow-calf type industries as well. This is a significant problem. I'm going to deal here initially just in a couple of slides here with the therapy of infectious lesions of the foot and foot skin. Basically, we know that we deal with those usually with systemic and with topical types of antimicrobials, antibiotics, and other antimicrobials. I think we look at the three primary, most common infectious disorders of the foot and foot skin. It would be bovine foot rot or interdigital phlegmon. That is usually treated with some form of an antibiotic, some systemic antibiotic. I'll mention a couple here in a moment that I'm familiar with, of course, from our work in the United States, but around the world it's similar, and there may be some other options that are more common, but I'll share some of the ones that we use. Then also digital dermatitis that we've just had a chance to be introduced to here with the person who originally discovered it. Digital dermatitis, we have treated with in the past with topical antibiotic therapy. We still do to some extent, although we're looking nowadays more and more at other types of non-antibiotic therapies. In the United States, we use copper sulfate as a topical so that we can avoid use of antibiotics for treatment of digital dermatitis. And part of the reason for that, of course, is that we all realize that resistance is a very significant problem. It's a health problem, and by that I mean it's a human concern, it's an animal concern, and so we're trying to avoid use of antibiotics except where it is absolutely necessary. Then secondary infection of the corium is a very common disorder in herds that have a high prevalence of digital dermatitis. We will find these lesions that occur on the corium itself, and so that can be a very stubborn, very difficult problem to treat as well. The antimicrobial therapy that is most commonly used in the United States, for what it's worth, and I realize that this varies around the world, but that what we utilize primarily is Ceftiofur type compounds or oxytetracycline. Penicillin actually still works for treatment of foot rot quite nicely, and so it's not always that we need to go to these newer generation type antibiotics, but Ceftiofur is one that is used quite frequently, and in the United States we use the popular formulation of this in Exceed, which gives us therapeutic levels of drug for a period of 7 days with no withholding for milk. And so that's quite popular, as you can imagine, with dairy farmers. And the 13-day withhold slaughter is also popular. That's not as long as, say, for example, oxytetracycline, which is closer to 30 days. And so it has a fairly short slaughter withholding for exceed, and we can bring that down even more if we use the other injectable forms of Ceftiofur as well. Other antimicrobials that are quite commonly used would include chlorphenicol and telithromycin. All of those are very effective, of course, but in general, it doesn't take any exotic antibiotics normally to treat foot rot if we get to this disease early enough in the course of its development. I'll have more to say about pain management here in a little bit, but I just want to mention quickly that at least in the United States, the most common approach to pain management is flunixin meglumine. It's the only drug that is labeled for pain associated with foot rot in cattle. And so it's the one that is normally used. The injectable formulation is 2 milligrams per kilogram. That has to be administered intravenously. It causes a pretty significant muscle damage when it's injected intramuscularly. So the intravenous use is the recommendation, of course, for the use of Banamine in the U.S. And so that's brought on in recent time then this newer formulation, transdermal formulation of phenidine, has made it a very, very popular option, as it is a pour-on administration. You simply pour it over the cow's back, they absorb it through the skin, and it works quite nicely for pain associated with foot rot, but only for foot rot as its label as far as its use in the United States for foot rot. I want to mention just quickly too, before I go on here, I want to talk a little bit about wound healing, and I think this will become more clear as we look at wound healing in general and the things that affect that. I think it's important when we think about wound healing in the context of claw lesions, it is primarily by what we would call second intention. That is, it's a spontaneous process. It's that method that we use from time to time to describe wound healing, where we've left the wound open and allow it to close by formation of granulation tissue, and then eventually reepithelialization of that granulation tissue surface, and then gradually contraction. At some point, this wound healing process matures. It is commonly used, of course, for contaminated or infected wounds, and that certainly is the situation we're talking about. We're dealing with foot problems in many cases, and these are quite contaminated or infected types of wounds. So the wound margins are allowed to close by reepithelialization and wound contraction that is assisted, of course, by myofibroblasts in the skin in particular, more so in the claw, of course, in claw lesions. The corium is resurfaced with new epithelium, and that is the major part of that process. And we'll talk a little bit more about that a little later on specifically. Hemorrhage and clot formation is generally the first phase of wound healing. Of course, if you think about a cut in the skin, we get hemorrhage that closes eventually because of platelet formation and so forth, that leads to this clot formation. That clot formation then we get from time to time, of course, in the corium, where we are trimming away a lesion of corium, let's say, a claw lesion, an ulcer, or white line disease kind of problem. In the process of our corrective trimming, if we do damage and cause hemorrhage, of course, we'll get the hemorrhage and clot formation phase of wound healing to occur there. Quite oftentimes, though, we can trim these lesions out without causing damage to the corium and causing any hemorrhage. So we get into the inflammatory phase of that process where we basically remove the loose and damaged horn around these lesions. It's important to understand, of course, we know that there's a migration of white blood cells into this tissue site that's already ongoing by the time we get to these in many cases. That also draws in inflammatory mediators and fibroblasts by chemotaxis, which is a critical part of this inflammatory phase. And then we move into this proliferative phase, which is the formation of granulation tissue, new blood vessels through angiogenesis, collagen, and reepithelialization process that ultimately closes this lesions and begins the formation of new horn over that particular lesion. Is also part of this process. Probably fits better when you think of it in the context of a skin lesion, but these processes all occur with respect to lesions that occur within the claw itself as well. Here we can see, if we look at this epithelialization process, it's where keratinocytes, and this is true of all claw lesions, is that we will get keratinocytes, horn cells, in other words, that are freed from wound edges, and they proliferate and move centripetally, that is, toward the center of the lesion. And if you're looking at this photo I have here at the right, you see there's a thin layer of new epithelium around that granulation tissue, and it's working its way. Those horn cells are working their way across that granulation tissue surface there to cover that lesion. So this is the process by which all claw lesions will heal, is pretty much through this formation of keratinocytes that are freed from wound edges and proliferate centripetally across the center of that lesion. The reepithelialization process, when it's complete, of course, it looks like this normal new horn again. And you know that in particular situation I'm showing you here in this photo, the epithelialization process is complete. That horn is still quite thin. That's a very thin layer of horn. But that is what we're looking for with all claw lesions, is this complete formation or reformation of new epithelium across this granulation tissue site, which is what we were looking at prior to this. This is what we expect to see in every case. That new horn that we see there is now going through the process of cornification, where it will gradually, those horn cells will go through this normal epithelial cycle from a very new epithelial cells where they mature and become cornified to become a new horn. And so this is what we're after. This is the objective in wound healing. So our wound healing objective then is the rapid, unimpeded reepithelialization of the lesion. When we find granulation tissues, you see here on the right, exuberant form of granulation tissue, as you see it there. What we see is then a situation where there's been an interruption of this whole process. And when that happens, then the formation of granulation tissue occurs. When we have that, we know that we have damaged, that epithelium is not, not resurfacing itself as it normally would, or that corium is not resurfacing itself as it normally would. In this particular case, it's granulation tissue. We trim it off flush with the wound edges there, but we most normally will end up with in most cases, a chronic lesion. Probably never will actually fully heal right. So granulation tissue is the indicator that we've had some form of interruption of that whole wound healing process. When we look at claw lesion healing rates, work by Shearer and others, but Shearer's work showed 74 cows with 105 claw lesions. Those that were considered mild lesions were normally resurfaced with new epithelium in about 25 days. Moderate lesions closer to 33 days. Those that were severe, as much as 42 to 60 days to be possible in those situations. So that gives you some rough idea of how long these will take to fully resurface and with new epithelium. I'm showing you here at the right on the 4 slides here. You notice at the top right there, number 1 and 2, you see the early lesion. As I'm just trimming it out here, this is a white line and a big Angus bull. And here on the item here on number 3, the photo here in number 3, you see some hemorrhage associated with trimming away all of this loose horn. We do as little damage to the corium as possible, but it's an inflamed tissue, and anytime you're up near it and anytime you touch it, it bleeds quite easily and quite profusely. And so that's possible. We try to be as careful as we can and try to avoid all bleeding if that's possible, but that's not always the case, of course. But what I want to show you, and what's most important about this series of slides, is that you see there by 21 days later, we have a new layer of epithelium there. So in reality, that lesion actually healed within, I'm guessing somewhere within the last week or so. So 14 to 16 days or so, that probably had a nice layer of new horn on it. And here it's got a very good, firm layer of new horn on it at 21 days after trimming that out. So you see then that we get these mild to moderate lesions, 16 to 33 days, severe lesions, a minimum of 40 to 60 days. If we look at the kinds of practices then that promote the healing of claw lesions, which is what we want to do, we can accomplish that primarily through just corrective trimming, a foot block, a good comfortable housing in the post-recovery period, and then also there's some work in recent time that the use of a non-steroidal anti-inflammatory may be of value to us as well. And I'll mention some of the work that's been done on that in recent time. Here's my point I want to make about corrective trimming and the use of a foot block. First of all, with the corrective trimming or therapeutic trimming is to remove all loose and undermined horn. It's important that you understand that what you're actually doing there is you're changing the microenvironment from an anaerobic environment to an aerobic environment. And when you do that, you see, you prevent further development of abscess formation. And really, the whole process is simply that, changing the microenvironment from anaerobic to aerobic, and we're doing that as careful as we can without causing damage to healthy corium tissues. Then we're going to adjust the weight bearing to get the weight off of it so that this thing can continue to go on and heal uninterrupted. And that's kind of what you see we've accomplished there in slide 4 there. We're moving on to the recovery phase there, and you can see that we've trimmed it all out. Not very much hemorrhage, just a little bit, but we've got all of the loose and undermined horn removed. I just want to say one thing about blocks, and here I'm going to skip away from some of the science just a little bit here, and so I share that with you so that you understand that it's an opinion and not hard science I want to share with you here. But what I have found over the years in putting blocks on large bulls, big bulls, 2,000 plus pound bulls, what I've found, I think, over time is that it's important the block thickness that we use. For example, blocks, as you well know, vary quite a great deal in terms of thickness. That ranges from anywhere from 6 to 25 millimeters plus. And the adhesive, of course, in some cases, like the one I have here at the right, this is a Bovibond. It's a type of adhesive that is quite commonly used in the US. You need to incorporate that thickness as well as the thickness of the block. The block is only 6 millimeters thick. It's a hard plastic block. I've gotten to where that's my preference when it comes to blocking. Because what I have found with overly thick blocks is that I get bursitis in shoulder joints, especially in bulls. I'll find when I put the bigger, heavy wood blocks on that completely remove all ability of this animal to redistribute weight to the two claws. What I end up with is, in many cases, in bulls, especially very large bulls, is I'll get some bursitis in the shoulder joint if it's on the front end. If it's in the case of a back foot, may develop an ulcer under the block, particularly if the block is on for any length of time. But I think that what I'm trying to get at is that I have gone to using thinner blocks over time, and partly because I think it's better to permit the animal some ability to naturally adjust the weight bearing between the two claws. If we remove all of the weight bearing by putting all on one big, heavy, thick block, and that just eliminates the animal's ability to adjust weight bearing at all, and that can be problematic in time. I think contribute to some of these problems that we see with respect to blocks causing this lameness. So it's important to look at our treatment, make sure that in the process of treatment, we're not also creating another problem for ourselves. And I guess I've done that enough over the years in my life that I am a little more sensitive to looking at those kinds of things. The other thing that I think is absolutely critical, and it just is overlooked so often, is that comfortable housing during the period of recovery is absolutely critical. If we put these animals in an area like you see here, and this is a lame cow area that a dairy uses, that particular dairy always gets the very best recovery rates from animals that have to be treated for lameness, because this comfortable housing in the period during recovery is really critical. Some animals really have difficulty managing to get up in a stall, or they're afraid to lie down in a stall when they're handicapped with a sore foot and one that's been treated. So I try to keep that in mind as well. Moving along, I'm going to talk a little bit about practices that delay healing. Bandages and wraps, surprisingly, those seem like the right thing to do. I don't think there's any real information that supports their use as being a positive. Topical therapy, I think we're still questioning that. I think that's one that needs a lot of research. If there's any of you out there who are interested in an area to consider researching, I think this is a good one. And digital dermatitis infections of the exposed corium require some treatment, and I'll show you some options on that. Bandages and wraps. I look at the U.S. and I get so frustrated at times. I work in the clinic at the college at Iowa State University, and I get so frustrated sometimes with some of our good clinicians downstairs who bandage and wrap absolutely everything that comes across the trim chute that has a foot problem on it. And it frustrates me because, as I'll show you, those can create real problems. But I also find that this is a routine procedure for so many veterinarians and hoof trimmers as well in the US. And when you look at the research on this, one of the first studies that I recall from this particular area of interest is done by White from New York. There was no group in the 3 groups that he studied in which bandaging improved the outcome of that treatment. And then a better study, I think, a nice study that was done recently by Clawwitter in 2019, healing was significantly higher for non-bandaged compared to bandaged sole ulcers. And so I think that we really need to question ourselves and what the benefit really is from bandaging and wrapping. I think that we're too quick sometimes to put these pretty nice red, blue, whatever color you want to consider putting on, because they look good. They look better than the lesion itself does, but in reality, I'm not sure that they do a great deal in terms of improving the outcome of our therapies. And this is also the case in equines. We find the preponderance of literature in the equine world says that bandages tend to delay healing of lower limb lesions and promote excessive granulation tissue formation. Possible reasons for that: bandages reduce the lesion oxygen tension. Oxygen is necessary for the angiogenesis that's occurring in these claw lesions or in these, and even in leg lesions for that matter. And it also is necessary for fibroblasts and the proliferation of fibroblasts, which are critically important in this wound healing process. Application failures are very common. They're often too tight or they're too loose. And in either case, they can compress the tissues and compromise blood supply if they're too loose. The movement of the bandage over the lesion surface can be a real irritant for the lesion itself. And so I think we need to be cautious, and especially when we're looking in the cattle world, especially in our dairies in the United States, our feet get very, very contaminated very, very quickly. They also, these lesions, these wraps can become very, very tight. And so we get some very serious lesions just from bandages and when we use bandages in those kinds of environments. And again, the contamination issue, it's nothing more than about, what, a half an hour, 45 minutes after you put a bandage on, that it's going to look like this one does. And you really have to question whether or not anything you put on that lesion underneath that bandage is really having any real benefit or effect. And so I caution you about the use of bandages and wraps. I think there's very little information that's telling us that's a good thing to do. Topical treatment of claw lesions, I think, is still a bit of a question mark as well. Here's a survey of veterinarians and trimmers showing that about 60% of veterinarians use it topical in the US. And when we did this particular survey, many of the hoof trimmers, about 53% did. Tetracycline and oxytetracycline were the compounds used most frequently, but many people used copper sulfate as well. And I tell you that if you ever look at these lesions a day or so after you put those kinds of compounds and medications on there, you will notice they do a tremendous amount of damage. They're not pH balanced, tetracycline and oxytetracycline, for example. They're acidic, they burn, make animals very uncomfortable. The same is true with copper sulfate powder. Animals get very, very uncomfortable if you put that on raw chlorine. And I kind of use the old adage, especially when I'm working in trimmers, if you wouldn't do it to yourself, don't do it to a cow, right? And I surely would not, under any circumstances, if I knocked a fingernail off or a toenail off, I sure wouldn't wrap it with tetracycline powder or solution or copper sulfate, either one. And so I think that we really have to question whether it's the right thing. And to go back again then to the study by White, he found delayed healing in the ones that he treated with a topical sulfanilamide and a bandage. And again, I say, I don't see the value of the bandage. I don't see any value in the topical sulfanilamide either, even though it might seem like that's the right thing to do because it is a contaminated lesion, right? It is a contaminated lesion, but the reality is Mother Nature has built into our systems enough protection there to get us to that point where reepithelialization of this lesion can occur with just a minimum of care. We also did a study in Iowa in 2015. I don't consider this by any stretch of the imagination a definitive study, but in our study, we found that those lesions that were treated with tetracycline or copper sulfate were more likely to cause granulation tissue, indicating an interruption in healing as opposed to healing. And reepithelialization was also reduced. So again, I say this is an area that I think needs a great deal more study. Neither one of these studies would I consider definitive. And so that's why I have a question mark behind the topic of treatment of claw lesions as a positive thing to do. Non-healing claw and toe lesions are a very common and important cause of non-healing lesions in cattle. Here we see one on the corium. You can see that granular surface that's very typical of a non-healing claw lesion that's affected with digital dermatitis. This is very prevalent, of course, in herds that have a high prevalence of digital dermatitis. And so it can be a real frustrating kind of a thing to treat. Now we're back to utilizing some kind of an antimicrobial in some cases. There are other medications that may work as well, but certainly some kind of an antimicrobial are of some value. This is one that Dr. Sarl van Amstel and I followed for some time. We treated it with, you can see here on the left, it's affected with the digital dermatitis on the surface of the lesion. Here we are at day 30 with a paste material that we had treated this with, containing injectable solution of dexamethasone and tetracycline powder. And you can see here that we're well on to the road to recovery here with a nice, very well healing lesion there. This is one that I really like from Dr. Johann Kofler. I stole this right from the book chapter he wrote that's in the pathogenesis and treatment of toe lesions in cattle, and that's in the veterinary clinics of North America. It's really a nice series here he's done of toe lesion healing. You can see here in A and B, this is when he's essentially cleaning it and preparing it, A, B, and C. Then in D, he's pretty much got it all debrided and cleaned. E, his topical tetracycline spray, this, and then put a bandage on. Now here in this case, bandages I think are a good thing where they can be managed on a regular basis. And these problems that I mentioned earlier on, you know, you don't have that issue when this is in a hospital setting. But in a farm setting, that's where I question the value of use of bandages. But in this situation, of course, he's managing this bandage, looking at it every day. And then you can see how it's recurring after 8 days of treatment, and 23 days later, it's nearly resurfaced. So these can be fixed and corrected, and it's important to see that approach. When these things have gone on for any length of time and you've got significant damage to the corium that could be, let's say, permanent to some extent or more permanent, or whenever this infection has gotten into the bone, I would always prefer, when I see these and I realize that it's in the bone and I cannot really get this thing corrected, otherwise, I do not amputate the digit. I just amputate the apex of P3, the third phalanx, just amputate the apex of that. And I think these animals do far better with that as opposed to amputation. Amputation is easy, but it's not necessarily the best method, in my view, for these ones to get into the bone and become chronic. Pain management, what is pain? Well, it's that unpleasant sensory or emotional experience associated with, resembling that with an actual or potential tissue damage. You can see that leg that surely doesn't feel very good. Sure, football player there. You look at the photo there on the right, circle that I have there in yellow. It's a leg fracture at the University of Florida football player. Is tackling actually a University of Alabama football player there that has a fracture in that leg. Looks like a really bad kind of fracture. And what I want to use that just to point out that there are several types of pain. All somewhat familiar with pain. You have acute pain. That originates, of course, in the peripheral nervous system. We have chronic pain that becomes very important in the context of claw lesions because over time we can develop a type of wind-up pain or hyperalgesic type of pain that is really the hallmark of claw lesions, and why we need to be aware of that, because what we'll see is, I'm going to share with you here in a moment, that when claw lesion healing, claw lesion pain that we get does not go away within a matter of a few days. It lasts through 28 days or more. So it's a very long-lasting kind of pain. So the nociceptive threshold is the minimum intensity of stimulation that causes a signal to be triggered by nociceptors, okay? Nociceptors are the receptors in the skin. The nociceptive threshold testing that was done in the work by Dr. Rebecca Way was to use a blunt pin that you pressed against the dorsal aspect of the metatarsus until the cow perceived the stimulus to be noxious. Of course, this is all in claw lesion type animals that were affected. And in this study, by Way, she observed that regardless of lesion type, all animals had a decreased nociceptive threshold at day one. They were all painful, right, at day one. But she noticed that at day 28, only the nociceptive thresholds of the acute digital tissue infection group were not significantly different from the non-lame group. In other words, those with the nociceptive thresholds for sole ulcer and white line disease were depressed not only at day 0, the painful at day 0, but they were also painful at day 28, whereas cows that had the acute digital type infection, that is foot rot, digital dermatitis, those were painful at day 0, but that did not persist. So here's an example then where we would use the flunixin meglumine, like I mentioned, previously, and we have studies that show that cows have visually improved lameness score, place more weight on pressure mats and so forth, following treatment with the Ruminants and meglumine, and then the transdermal that I mentioned earlier on, phenidine, also improved lameness scores and increased contact force when walking across pressure mats. So we know that those are very effective. Claw lesions, we know now, as I mentioned just a moment ago, claw lesions in cattle are characterized by hyperalgesia, right? Hyperalgesia. A pain that is such that smaller stimulus creates an even greater reaction. And we know that dairy cattle, Dr. WAB proved this in her study, and I mentioned it just a moment ago, but dairy cattle with claw lesions are in hyperalgesic state. Just have to get that in our mind, that these animals will be in hyperalgesic state that will last at least 28 days after this claw lesion was originally treated. And we're talking about sole ulcers, white line disease, even foreign bodies that we might get, sole ulcers, the toe ulcers, I should say. All these are the kinds of things that would create for us this hyperalgesic pain and this hyperalgesic state that lasts for at least 30 days or more. So again, I come back to how we go about treating these. Well, we're going to use our foot blocks to treat these, because the relief of weight bearing does provide pain relief for us. I just tried to point out some watch outs with very thick blocks in some animals that I think you need to be conscious of. And then also, I think that you'll find when we're treating these claw lesions, because of this pain and this complicated kind of pain that we get, that drugs like meloxicam in our case, or gabapentin, or ketoprofen would be the kinds of drugs that maybe more folks would use internationally. For us, we approach these with meloxicam and gabapentin. These are, the meloxicam is an NSAID that works very nicely for us in treating lameness. So meloxicam, we know the studies that have been done with it improved lameness scores in cattle with clinical lameness. The use of meloxicam for 4 days following resection of distal interphalangeal joints was effective in a study by Offinger in cattle that have been experimentally induced with lameness. We got very, very good results with meloxicam as well. And then when we have this hyperalgesic pain that is really significant in animals, this wind-up type pain, we will add gabapentin to the meloxicam, and they tend to work synergistically to give us a little bit better results when we're dealing with this even more complicated kind of pain. And of course, I know that for many that are listening here, ketoprofen would be more familiar. Ketoprofen is very effective, and there's lots of studies with it. Recent time, cure rates of cows with claw lesions were improved with therapeutic trimming of foot block and NSAID treatment by Thomas and Sadiq. Animals that were receiving therapeutic trim block, 3D course of ketoprofen are more likely to have an improved non-lame outcome as well. So we see some good benefit there from using an NSAID, or non-steroidal anti-inflammatory, at the time of treatment. And then we also have, of course, the other types that maybe didn't work so well. Here's one with tolfenamic acid that was done by Dr. Richard Lavin from New Zealand. He found the opposite. There were no significant differences between treatments in his particular study. So therapeutic trimming and a foot block alone were sufficient to improve locomotion scores and reduce allodynia. So there are other dissenting studies as well. And here's also another one, and this one's by Thomas, where they treated chronic claw lesions, and they found that they weren't able to overcome some of these effects of hyperalgesia in chronic lame animals. So treatment delays are likely. Then the point is that if you delay treatment and you get yourself into this situation where you have this hyperalgesic state, it's going to make it so that it's going to be very possible that you'll have difficulty controlling that pain. And here I'm drawing to a close here, and I just want to mention one other study. This one by Wilson that showed that treatment with an NSAID at the first and subsequent calvings every time animals were identified as lame reduced the lifetime probability of lameness, severe lameness, and culling in a 3-year random controlled trial that they conducted. The researchers hypothesized that the systemic inflammation that occurs around the time of calving in that early postpartum period and localized inflammation associated with lameness predispose cows to future lameness that may be limited by routine treatment with an NSAID. I just end with this, that I think that multimodal approach to treatment is an important one. And I start up here at the upper left, an IV regional therapy, when we're treating cows that have painful claw lesions, and we know that's going to be annoying and painful for these poor animals when we're trimming these things out. Go ahead and use IV regional anesthesia there. Do a careful job of corrective trimming. Do as good a job as you can in removing the loose and damaged necrotic horn without damaging the corium. Avoid the irritating topical treatments. We know there are many out there like that. Iodine is irritating. The tetracyclines are irritating. Copper sulfate is irritating. So you want to try to avoid those. Use of a block is very important, I think, in any of these conditions, but I question whether or not we want the super high block completely eliminate all weight bearing, because I think that that can create problems for us as well. And then the other thing I don't want you to ever forget is the comfortable housing during the recovery period is really a critical part of it. And I think there's good evidence for the use of NSAIDs at the time of treatment and possibly in the early postpartum period. I'll leave it at that because I see that my time is just about up. But hopefully I've given you some thoughts there and some things that you maybe can think about the next time around that you have an opportunity to treat some of these kinds of foot conditions. Dr. Gentile, I'll just say to you.
Thank you, Professor Shearer, for the very interesting, outstanding presentation. Very clear, with a lot of aspect. I don't know whether there are questions. Usually we don't have, give time for questions, but if I want to see whether, yeah.